think it's sequencing, but I think even more tricky is to determine what to start a patient on up front. There are clear cell renal cell carcinoma comes in many different shapes and sizes, and can be very aggressive or can be very indolent, and we don't always know that up front. And so learning how to risk stratify patients from the outset, and then how to balance the drugs that we have based on their efficacy and their tolerability, I think is really the key. As monotherapy in the first line, I don't see a role for examining the role of other TKIs. We've already seen a phase 3 trial looking at axitinib compared with sorafenib. That was a negative study. There were a number of shortcomings with that study. That doesn't mean it's a bad drug. But I think now that we're seeing these immunotherapy tyrosine kinase inhibitor combinations, or immunotherapy VEGF antibody combinations, that I think are going to take over the first line. So as a monotherapy, I don't think that we're going to see any more clinical trials looking at other TKIs, but in combination, I think certainly axitinib, lenvatinib may play a role there as well, but we'll have to wait and see how the clinical trials turn out over the next 2 years.